So today's class is on diphtheria. Myself Dr. Ramya Ramachandran. So today's specific learning objectives include, at the end of this session, the students should be able to describe the epidemiological determinants of diphtheria, list out the clinical features of diphtheria, and list out the preventive methods of diphtheria. So what is diphtheria? It is an acute toxic infection caused by Corynebacterium diphtheria, and it is rarely caused by another strain which is called as Corynebacterium ulcerans. So what differentiates between the two? So we can do the urease test which can in which Corynebacterium ulcerans is urease positive. Now regarding the epidemiological situation in India, diphtheria is a disease which is endemic to India. Now what are the epidemiological determinants of diphtheria? So as you all know, epidemiology consists of something known as an epidemiological triad, and it consists of three main factors. One is the agent factor, one is the host factor, and the environmental factors. So what is the agent factor of diphtheria? So obviously it is the Corynebacterium diphtheria which is the causative agent, but there are four biotypes of Corynebacterium diphtheria. One is the mitis, one is the intermedius, one is the Belfandi, and the other is the gravis type. Organism is aerobic nature, non-encapsulated, non-spore forming, and it is mostly non-motile, and it is also pleomorphic in nature, and of course it is a gram-positive bacilli. Now the very important feature is that it produces a very powerful exotoxin which can result in myocarditis as well as nerve damage. Now what is the source of infection? One is the case, one is a diphtheria case, and second one is the carriers. So there are different types of carriers. So in the case of diphtheria, it is mainly temporary or chronic carriers, or it can either be nasal or throat carriers. Now what are the infective materials? So the infective materials include nasopharyngeal secretions, discharges from the skin lesions, contaminated fomites, infected dust. So what is the period of infectivity? So from the period of onset of the disease, it is 14 to 28 days. Now coming to the second main factor, which is host factors. So the disease mainly affects children in the age group of 1 to 5 years. So there is no particular age gender predilection as such. Both the female as well as the male gender are equally involved. Now if at all the mother is immune and the mother has acquired immunity, the probability that the infants born to such mothers will also have immunity for the next few months of their infancy. Now the resistance to the disease depends on the availability of specific neutralizing antitoxin in the bloodstream or the tissues. Coming to the third main factor, which is the environmental factor, winter months favor the spread of the disease. Mode of transmission, I have already talked about the respiratory and the non-respiratory part. So the mode of transmission include droplet infection, the infected cutaneous lesion, and the portal of entry is respiratory as well as non-respiratory. Non-respiratory route include skin cuts, ulcers, umbilicus in the newborn, the genitalia, eye, or the middle ear. The incubation period ranges for a very short period of time, which is 2 to 6 days. Now clinical features, there are mainly three types of diphtheria. The most important of which is the pharyngotonsillar one, then we have got the laryngotracheal one, then we have got the nasal diphtheria. So in pharyngotonsillar one, as the name suggests, you will have throat infections, throat pain, or you might have difficulty in swallowing, and also certain constitutional symptoms which might include mild fever. And on throat examination, you will find mild erythema, localized exudate, and a very important characteristic feature which is called pseudomembry. So what is this pseudomembrane? Pseudomembrane is a membrane which is localized or which occurs in patches on the posterior pharyngeal wall or on the tonsils. Now initially it is localized, it can extend to the soft palate as well as the hard palate, and it can even cover the entire tonsil. So in the early stages, it is usually whitish in nature and it can easily be peeled off. Now as the disease advances and if the detection is getting late, it might get more deep rooted and removal might be more difficult, and the color itself will change from whitish to grayish black, and trying to remove it may result in bleeding. And another very characteristic feature is the marked edema of the submandibular area as well as the anterior portion of the neck. And there is the lymphadenopathy, which can result in the characteristic bull neck appearance in diphtheria. So this is a photo which shows the bull neck appearance in this particular child. And coming to the second type of diphtheria, which is the laryngotracheal one. So again, constitutional symptoms like fever, croupy cough, dyspnea and hoarseness can occur. Nasal diphtheria is the mildest form of diphtheria, and it occurs if at all, if a person is affected with nasal diphtheria, it will involve the either side of the turbinate or the nasal septum. Now what is the pathogenesis of diphtheria? What actually occurs in the membrane area, the pseudomembrane part? So the diphtheria bacilli within the membrane can produce the active toxin, and it can result in parenchymatous degeneration of the muscles and necrosis in the heart muscles, liver, kidney. And what happens is that the heart rhythm will turn irregular. There can be paralysis of the soft palate, eye muscles and even the extremities. So the control is mainly aimed at cases and carriers, the contacts, and finally, very importantly, the community. So what do we do about the cases and carriers? First and foremost, the mainstay is early detection, and we have to do nasal and throat swabs. Second is isolating the particular cases or carrier. So all suspected cases and carriers should be isolated for a period of at least 14 days. Now if at all you want to be removed from the category of isolation, you should have your swab taken. That is, your nasal or throat swabs or nasal and throat swabs can be taken 24 hours apart, and both of this should be negative for the isolation to be entered. Now the treatment. So for treatment in diphtheria cases, we can give the antitoxin in a dosage of 20,000 to 1 lakh international units, either intravascularly or intravenously. In addition to that, you should also, every case should be treated with penicillin or erythromycin for a period of 5 to 6 days. Now for carriers, what do we give? We give a 10-day course of oral erythromycin. Now we have already talked about the cases as well as the carriers. Next is contacts. So what do we do about the contacts? So we get their throat swabbed. We have to swab the throat of the carriers. Now next, what do we look for? We should look at their immunization status. So if at all they have taken the primary immunization or booster dose within the previous 5 years, no further action is needed. Now if it has been more than 5 years since the primary immunization or the booster dose has been taken, go for a booster dose of the diphtheria toxoid. Finally, if the close contact is not immunized at all, neither with the primary dosages or primary immunization or booster doses, we can give prophylactic penicillin or erythromycin. We can go for antitoxin in a dosage of 1000 to 2000 international units, and also very importantly go for active immunization of the said close contact. community, even though it has been kept to the last, it is the most important. You have to give diphtheria toxoid of all the infants, follow the immunization schedule of the country, and it should be given as early in life as possible with subsequent booster doses. So the mainstay of prevention obviously are the vaccines of diphtheria. So we have got many types of vaccines in diphtheria. So the combined or mixed vaccine, we have got combined vaccine, we have got single vaccine, we have got the anti-sera one for the prevention. So firstly we will deal with the combined or mixed vaccine. We have got the DPT vaccine, we have got the DTPW, which is diphtheria, tetanus and the whole cell pertussis vaccine. We have got DTPA vaccine, which is diphtheria, tetanus and acellular pertussis vaccine. We have got DT vaccine, we have got another DT vaccine, which is the adult variant, and we have got the pentavalent vaccine. So what is the storage conditions of a DPT vaccine? DPT vaccine should be stored between 2 to 8 degrees Celsius, and 3 doses in a dosage of 0.5 ml at least 4 weeks apart should be given. So in infants, according to our immunization schedule, we give it at 6, 10, 14 weeks. So we usually do not give DPT vaccine as such, we give it as a combination of hepatitis B and Hib, which is also known as the pentavalent vaccine, which I was mentioning earlier. So pentavalent vaccine, which consists of DPT, hepatitis B and Hib, is given at 6, 10 and 14 weeks. Then we give the booster at 16 to 24 months, and another booster is given at 5 to 6 years. That is only DT. And where is it given? It is given on the anterolateral aspect of the thigh intramuscularly. And what are the contraindication of this vaccine? So if at all you had a severe, if the patient had a severe adverse event to the previous dose, or any reaction, convulsions or neurological symptoms, the vaccine is contraindicated. But mild fever and localized pain at the site is expected in any pentavalent vaccine or DPT vaccine. Now coming to the single vaccines, which is rarely given, we only opt for the DPT, DT and the pentavalent vaccines. Single vaccines is the FT, formal toxide, APT, alum respirator toxide, PTAP, which is a purified toxide aluminum phosphate, PTAH, which is a purified toxide aluminum hydroxide, and finally we have got the toxoid antitoxin flocculus. As I said, the single vaccines are rarely given. It is not at all given in our country. Anti-sera is prepared in horse serum, and it is the mainstay of passive prophylaxis and the treatment of diphtheria. So this sums up the control of diphtheria. It is the mainstay is obviously vaccine. We have got 3 types of vaccines. One is the combined vaccines. We have got 2 broad classifications of vaccine and then the anti-sera. So the first broad classification is the combined vaccine, second is the single vaccines, and then we have got the anti-sera. And the most important of which is the combined vaccine, mainly pentavalent, DPT and the DT ones. Thank you.